Welcome to QD Clinic. Hi, I'm Dr. Jack Cush with RheumNow. QD Clinic is brought to you by RheumNow.Live 2023, March 18 and 19 in Dallas, Texas, or virtual on your computer. You can be there. You know, teachers teach, but RheumNow.Live is really about the lessons that belong to you, the learner, meaning we want to hear from you. You're involved in these interactive sessions we're going to have on RA, PSA, lupus, vasculitis, spondylitis, etc. Come, we'll master rheumatology together. Today's case is a new paradigm in polymyalgia rheumatica. So a 68-year-old woman comes in with complaints of leg pains, hip pains. She has had this for the last 2 months. Previously, no trauma, no musculoskeletal problems, no osteoporosis, no fractures, and she just found that she could no longer function. Woke up in the morning dragging, really profound morning stiffness, having a hard time getting dressed, having a hard time fulfilling her community activities, her family activities, and of course, she's diagnosed as having polymyalgia rheumatica when she's found to have an anemia, chronic disease, an H&H of 11/32, a thrombocytosis with a platelet count of 545,000, a SED rate of 113, a CRP of 31 milligrams per liter. Her LFTs were normal, her CK was normal, her strength was normal, but she was really slow moving. This was a no-brainer. Love seeing patients with this presentation and diagnosis. My starting dose is 15 milligrams a day, and of course, she came back 3 weeks later and was dramatically better. And the question is, how do you treat polymyalgia rheumatica? I bring this up because she presented actually before the new FDA approval of an IL-6 inhibitor for PMR. That happened on the 28th of February. Sarilumab was approved based on the results of the Sapphire study, and the indication there is Sarilumab, the IL-6 inhibitor, is indicated in patients who are refractory to and cannot wean their steroids. You have to have a diagnosis of PMR, of course, but then again, where is this going to fit? And the question is, where will you use an IL-6 inhibitor now that we have one approved? And I would imagine by the end of the year, or certainly by next year, we might have at least 2 IL-6 targeted drugs approved, and maybe even other therapies approved for PMR, and maybe other therapies approved for GCA. So this kind of happened when tocilizumab was approved for use in giant cell arteritis. The question was, how is it going to change the paradigm? And I think the answer for both conditions, whether it's GCA and tocilizumab or polymyalgia rheumatica and sarilumab, it's going to change slowly. Why? Well, because you, the rheumatologist, are sort of addicted to steroids. I mean, they're easy to use. They're dirt cheap. And in the case of PMR, 15 milligrams is all you need. Rarely do you ever need to go up as high as 25. And the question, and you think you're going to tell the patient that, don't worry, you'll be off the steroids in 1 to 2 years. And of course, that's wrong. The vast majority of patients are really on for almost 4 to 5 years. So do you want to commit your elderly, usually white Caucasian patient with PMR to 5 years of steroids? Maybe that's okay for many patients, but ones with diabetes and heart failure and other significant comorbidities, that might be a bad choice. In 2015, the American College of Rheumatology and EULAR proposed treatment guidelines for PMR. And they, number one, said don't use nonsteroidals. They don't work. They're not recommended. They also said don't use TNF inhibitors. They don't work. They're not recommended. They are against natural products. They don't work. They're not recommended. They strongly recommended a course of glucocorticoids that are individualized to the patient with a starting dose of 12.5 to 25 prednisone equivalents per day. And then basically you want to keep the patient in remission with normalization of symptoms and their acute phase reactants, their inflammatory indices, really within a month or two and being stable and in remission for at least 3 months before you can wean their doses. Again, the guidelines did say doses no less than 7.5 and no higher than 30 milligrams with treatment of PMR. Of course, this gets a little bit dicey when the patient has PMR and RA overlap with some swollen joints. I still call that PMR, but I might call that RA if I want to use an RA drug to treat it. Anyway, you basically can wean their steroid doses every month to every 2 months to hopefully a dose of 10 milligrams per day, and then show that they're in remission for at least 6 months before you start to wean any further. Now, again, this is often a futile effort because patients will flare, and they'll flare because you're weaning the steroids and they're going through steroid withdrawal. So you need to have clear-cut guidelines on what you're calling a failure. The question is, what else where can you add other therapies? The guidelines from ACR and EULAR say that you add methotrexate when the patient is refractory to steroid weaning or has complicated diseases that would permit you to not use or forbid you from using high-dose steroids. Now I think you're going to add the IL-6 inhibitor to that list. And maybe it's going to be after you fail methotrexate that you would move on to an IL-6 inhibitor. Maybe in patients who can't take methotrexate, you use the IL-6 inhibitor. Maybe patients who are incredibly high risk for steroid side effects, maybe you'd use the IL-6 inhibitor. Time will tell how the paradigm is going to change. I do think it's going to be slow, but it will change. This is a major advance that we should all take note of. Take care.